Thank you. First of all, good morning to everyone and welcome to the VACCELERATE webinars. Thank you very much for joining. Actually, today we have a great pleasure and honor to welcome two excellent scientists from the UK. Professor Paul Heath, Director of the Vaccine Institute of St. George's University of London, UK, and his colleague Eva Galiza, Senior Clinical Research Fellow. They will present to us the results of a platform trial entitled Preg-CoV trial, which is actually a very important trial trying to assess the optimal time and dose to administer COVID-19 vaccines for the best protection of pregnant women and their infants during the pandemic. And as you can imagine, this specific trial is very, very important from several points of view. First of all, because it will provide us with precious data with regards to vaccine safety in a pregnancy vaccine trial during the pandemic. And of course, also some lessons learned that we can discuss after the presentation about platform trials and the future implications for preparedness reasons and for future vaccine evaluations. So before giving the floor to Professor Paul Heath, I would like to remind you to write your questions in the Q&A VACCELERATE box to moderate a fruitful discussion after the presentation. And with that, I would like to give the floor to Professor Paul Heath to start his presentation. Thank you very much.
Well, thank you very much, and good morning, everyone. It's a pleasure to be presenting today. And yes, we would like to present the Preg-CoV trial that we've been doing and are still doing, in fact, in the UK regarding COVID-19 vaccines in pregnant women. And what we want to share with you is the trial and tribulations, I think, some of the many issues that we've had to deal with in conducting this trial in pregnant women during a pandemic. And then toward the end, we do have some preliminary results, which we're very happy to share with you. We don't have the full results yet. The trial is still going, and we therefore can only present a relatively limited number of data and conclusions, but hopefully some that you will find interesting. But I think this is also an opportunity to discuss pregnancy trials, particularly with vaccines, and also thinking ahead towards perhaps the next pandemic. So just to begin, some conflicts of interest. So Eva and myself work on behalf of the University of London as investigators, which are funded or sponsored by vaccine manufacturers, although all of this funding goes to our employer and not to us. And I'm also a member of the UK Joint Committee on Vaccination and Immunisation, but what I'm talking about today doesn't is my own individual opinions. All right, so just to think about COVID-19 in pregnant women, and I'm sure this audience, of course, is well versed with the issues, but it became clear fairly early on in the pandemic that the outcomes in pregnant and recently pregnant women with COVID-19 were in many respects worse than that of non-pregnant women. So this systematic review and meta-analysis is very helpful. So the first set of outcomes is comparing pregnant women with COVID with non-pregnant women with COVID. And perhaps what you can see is the higher odds ratio of ICU admission, invasive ventilation, and need for ECMO in pregnant women with COVID. And then comparing pregnant women with COVID with pregnant women without COVID, there was a clear increase in mortality, ICU admission, preterm births, and in stillbirths, and in admission to the neonatal unit of the babies born to these women. So clearly an increased burden of disease in this population. Yet, we all recognize the limited evidence base for making decisions around vaccination. And this is a snapshot from the London School website, which has been recording all of the COVID vaccine trials over time. But the point I want to make here is that the majority of the COVID-19 vaccine platforms, particularly RNA, DNA, replicating vector vaccines and the like, had never been assessed in pregnant women before the pandemic. And indeed, all the pivotal trials of all of the COVID-19 vaccines specifically excluded pregnant and breastfeeding women from participation. So, of course, it meant that the decisions around vaccinating pregnant women needed to be made without any clinical trial evidence in this population. So they were made based on general principles. So the general principles of vaccinating pregnant or breastfeeding women include the fact that there is no evidence of risk with inactivated virus, bacterial vaccines, or toxoids, that inactivated vaccines do not replicate and so cannot damage the fetus, and that live vaccines are generally contraindicated in pregnancy. Although, of course, this is for a theoretical risk of fetal infection. And indeed, there is no evidence to date of direct fetal injury as a result of inadvertent vaccination in pregnancy with a live vaccine. And of course, particularly relevant to several of the COVID-19 vaccines, the adenovirus-vectored vaccines, is that though these contain live virus, they do not replicate and therefore, in principle, do not pose a risk to the fetus. So coupled with that, we had reproductive toxicity data. So all of the manufacturers were in fact doing developmental and reproductive toxicity studies in animals, not quite in parallel to the clinical trials, somewhat later. We can discuss that later. But all of these animal studies, of course, did not indicate any direct or indirect harmful effects of vaccines given to pregnant animals on any of these aspects. And of course, during the course of the pregnancy trials, there were quite a large number of women who were pregnant and who were in a shows that there were no concerns. And then, of course, as vaccination began to be rolled out, we were gathering data through various safety databases and registries, for example, through CDC and in the UK through MHRA. So here's an example of the accidental pregnancies in trials for the COVID-19 vaccines in the UK. And this was just looking at miscarriages. So these were women who were inadvertently vaccinated in the trials. And there was no increased risk of miscarriage, which was clearly an important point. But the question then became, well, what other information do we need about vaccinating pregnant women, given that there are no clinical trial data at all? And though there was a lot of observational research that was ongoing, addressing a range of questions regarding safety and immunity, such research would not necessarily address specific questions that could only be addressed through clinical trials. We felt that further data were required, including the optimal dosing intervals for immunization during pregnancy to protect mothers and babies. And I'd just make the point here, of course, that when we started, I think it's fair to say that we were thinking about protecting pregnant women against COVID-19 because there was clearly this excess risk. As time has gone on, of course, we've been able to see that there is a role for vaccines in pregnancy in protecting infants. So the goal has perhaps shifted a little, or rather now trying to encompass both of these needs. We needed further data on the reactogenicity and safety of all available COVID-19 vaccines in pregnant women. The need for and reactogenicity of additional doses with each pregnancy. This became clear as time went on. We started with 1 or 2 doses in pregnancy, but obviously as the program has moved on, the need for booster doses and the timing of them and the acceptability of them. Co-administration with other routine vaccines, pertussis-containing vaccines, for example, influenza vaccines. And then, indeed, perhaps more toward the start of the pandemic, there was a question around the role of fractional doses. Could fractional doses of COVID-19 vaccines be deployed in pregnant women to minimize reactogenicity, which is always a concern in pregnant women, but potentially without any loss of immunogenicity? we felt it was important to gather these data in a systematic and controlled manner, so in the context of a clinical trial. So we had early discussions with the UK government vaccine task force in March 2021, who were supportive at this point. We were also aware that there were no other trials taking place, as I've already mentioned. This is the London School website, which is still current, which is just showing COVID-19 vaccine trials in pregnant women. So the top one here is ours. And then we have two large commercial studies, the Janssen and the Pfizer, neither of which, to our knowledge, have been published or presented data yet. And then we have two smaller phase 4 studies, one in the Netherlands, one in Belgium. So the concept was for Preg-CoV using an adaptive platform design to assess the immunogenicity and reactogenicity of different schedules of approved vaccines, to include new vaccines as they were approved, and to address any new questions of relevance to the UK vaccine programme as required as the programme moved on. So I'm going to pass over to Eva now to take us through the objectives of the trial. Thank you, Eva.
Thank you, Paul. So yes, this was an adaptive design in where we were looking at immunogenicity and reactogenicity of COVID-19 vaccines in pregnancy, with the primary objectives here was to look at the immune response to immunization according to a long interval dosing between the first and the second COVID-19 vaccines, compared to a short dose. And the intervals there you can see are the short dose being 4 to 6 weeks and the long interval being 8 to 12 weeks. We also wanted to look at the reactogenicity of these COVID vaccines when given as a 1 or 2 dose vaccine regimen in pregnant participants. Another primary objective here was added later. I'll talk about all of the changes that were made to the study with the addition of cohorts. So we wanted to look at fractional dosing, as it was a question that we felt needed to be answered. So that was an additional primary objective added later. And then moving on to secondary objectives, we wanted to look at the pregnancy outcomes and also safety. So looking at serious adverse events, medically attended adverse events, and those of special interest as well. So we collected all that data for the participants who had their vaccines in the trial. We also wanted to assess the immunogenicity of these vaccines when given as a 1 or 2 dose in the trial. Again, later on, we had an added cohort and we wanted to look at the effect of co-administration with routine vaccines. And for this study, we used the pertussis-containing vaccines. Now looking at secondary objectives for the infant, we wanted also to look at the safety of infants, of those who are born to women vaccinated with COVID-19 vaccines. And we follow them up to 12 months of age. And we also looked at the transfer. We'd also like to look at the transfer of antibodies and the kinetics of these maternal antibodies. There's a range of other things that we are looking at as well, which is the effect of gestational age, interval between vaccination and delivery, maternal age, health status, vaccine type, and schedule. More exploratory objectives. We had a lot of samples that we can look closely at getting descriptions of antibodies in the breast milk. We also wanted to delve into immunogenicity of COVID-19 vaccines as boosters, so that we can have a clearer idea if we were looking at further boosters as pregnancies, subsequent pregnancies. Again, looking at the booster doses given to participants who've already had previous vaccines, whether they were in the trial or outside of the trial, and also the impact of prime boost interval on immunogenicity when given to those who've already received a prime dose of COVID-19 vaccines before pregnancy. In addition, we wanted to look at the effectiveness of COVID-19 vaccines in pregnancy. So we would take the opportunity to look at symptomatic participants, both mother and infant, so that we can have a clearer idea of the effectiveness there. So to enable us to reach far and wide across the UK and also recruit as many participants as we can, we enlisted the help of 12 other sites. So there were 13 sites involved in England, and they worked extremely hard to recruit participants and to keep up with all of the changes that were made in this study. So this table shows you the different cohorts that were included in the trial. As you can see, it's quite a complex trial with the addition of other cohorts as well. So I'll just start off with cohort 1 and 2. So those were looking at the effect of a 2-dose primary course in pregnancy. So that's the first 2 doses. We had cohort 1 who were randomized to receiving one of 2 vaccines that were available at the time, Pfizer and Moderna, and they were also randomized to the short interval and long interval. So this group was blinded to both the interval and blinded to the vaccine that they received, and we used the pertussis vaccine as the blinding vaccine there. For cohort 2, these were for participants who had already received a pertussis vaccine or did not wish to receive a pertussis vaccine. So they were blinded to their vaccine, but not to the interval. Cohort 3, we're looking at those participants who may have been recruited much later, and so we wanted to look at the effect of 1 dose of COVID-19 vaccine in pregnancy versus 2. So they would have received their first dose during pregnancy and their second dose shortly after delivery. I'll talk about this later, but we had made amendments to this to allow for these participants to receive their second dose as per national policy, as things changed in the national programme. For cohort 4, we were looking at the effect of a booster vaccine previously. So that was a second dose, but we shortly afterwards adapted that so that we could include booster doses, so they could have received their 3rd or 4th dose as well. So that's cohort 4. Cohort 5 was an addition later on in the study to account for those who've already had their prime course during pregnancy or have had at least 1 dose during pregnancy. And this was an observational cohort. And then cohort 6, as I said earlier, we were looking to see if the impact of fractional dosing and co-administration with pertussis vaccine. So that was included in cohort 6. So as you can see, very complex and lots of changes that occurred there. This is just an example of the complexity of the visits themselves in order for us to get the details or the data that we require to answer some of these questions. So as you can see, there are quite a few visits. This is, for example, for cohort 1, and dependent on when the mother would be recruited to the trial, they may be seen 9 times during the course of the trial. And we also incorporated some telephone follow-ups as well to alleviate the timings of the visits. As you can see, there are many blood sample time points here as well for mother and also for you for baby, and also breast milk and colostrum visits as well. We would also ask the participants to record reactogenicity by completing e-diaries throughout. So this is just a list of the eligibility criteria. So essentially we were looking for participants 18 to 45 years of age, singleton pregnancy, between 13 to 36 weeks gestation. And the inclusion-exclusion criteria, we tried to keep it quite straightforward and simple, so that this could be a pragmatic study to allow for inclusion of participants. So they needed to comply with study requirements of all the visits. We needed access to their medical records, and they have no contraindication to vaccines. Moving on to the recruitment strategies, we had multi-pronged strategies here to try and reach far and wide. So we had leaflets and posters that we'd be using in the clinics and also in their medical records, handheld medical records. We would use institutional websites and hospital universities, various social media, local and far and wide, with press release organised by our funders, the government, UK Government Vaccine Task Force, as well as the NIHR, the National Institute for Health and Care Research, and also the Royal College of Obstetricians and Gynecologists. We had face-to-face screening in clinics, which proved to be the most effective way of recruiting. We'd also use a mail-out where we would send invitations to those who were eligible through our database. And we'd also enlist the help of the NIHR Vaccine Registry, which was a registry of healthy volunteers who were interested in taking part in research in general. We also had QR codes, which were handy, that we could use in the handheld notes for participants to get more information about the study. So the next slides are just examples of the recruitment strategies. So these are the posters and patient information leaflets that we use. Quite wordy, but something that we need to include all of the details within that. And this is just to indicate, to show you the use of the NIHR Vaccine Registry, which I mentioned, which was centrally coordinated and allowed us to have access to a number of participants. And also we used this, their database and the system by advertising through their newsletters as well. So this is a study timeline to show you how quick and fast moving we were and tried to be, but we often came across some barriers here. So the concept and the design of the study was back in March 21, and we had sought feedback from the MHRA that same month, which we got approval, and some support from the Vaccine Task Force the same month as well. We confirmed funding the following month, and we managed to get REC approval, ethics approval in June, with MHRA approval in June, and then we started the study on the 16th of August. So you can see that we pushed really hard and worked really hard to get the study going up and going as quickly as possible. The next slides show you the timeline in detail. So in August, as I said, we opened to cohorts 1 to 4. But we shortly after that knew that we needed to make some changes to allow for for inclusion of more participants into the study. So we, as mentioned here, addition of PIC sites, participant identifying centres for rapid recruitment. We removed an exclusion criteria, which was the previous microbiological diagnosis of COVID-19. We made allowances for sites to see participants for separate screening for ease for them. We also extended home visit timing of post-delivery for the collection of delivery bloods if they weren't taken in the hospital at delivery. We changed recruitment windows for certain cohorts, again, to allow greater inclusion, and also changed cutoff points for booster doses, again, to allow inclusion. So with that, we still saw a slowing down of recruitment between those 3 months in August and November. So we did look to see if we could include those participants or those eligible participants who already had 2 doses of a vaccine outside of the study. So that would be the inclusion of cohort 5. Along with that, we had an amendment, various other amendments to align with national policy, as I mentioned earlier, to allow cohort 3 to have their booster dose. And as you can see here, in November 21, we had the inclusion of cohort 5, a change to cohort 4 to allow for a second and third dose, and not just a second dose there. In December 21, we saw the JCVI, Joint Committee for Vaccination and Immunizations, who advised vaccination in pregnancy. We then wanted to look at the addition of cohort 6, which I mentioned earlier was the fractional dosing and co-administration. We worked towards that, and that was open in June 2022. So it's an ongoing study. We're still looking, we're still following up our participants as we have 12 months post-delivery of follow-up visits. Currently, we have now closed to cohort 6, as it was deemed that this may not be a relevant question to ask in the national programme currently. But we are looking to see if we can look at additional arms with new bivalent vaccines. So this is just a graph, a cumulative recruitment graph by month to show you the rate of recruitment over the months from start to October 22. We've recruited up to 320 now. And this is to just give you an idea of the rate of the coverage of COVID-19 vaccine in pregnancy. With the JCVI in the first arrow, you can see there where their recommendation was for vaccination in pregnancy, and then you can see a steep climb in recruitment, and then Preg-CoV starting in August 21 there. So had we started earlier, maybe we would have seen a steep increase in our recruitment. So this is just to show you the enrollment and how many we were recruited to the different cohorts. So 320 total enrolled, with the numbers there for the various cohorts, with the greater number seen in cohort 5 with 228. And again, that was the observation arm. So just as a reminder, cohorts 1 and 2 were looking at 2 vaccines in pregnancy in the trial. Cohort 3 was 1 vaccine in the trial. Cohort 4 was 1 vaccine, either the second dose or a booster dose. Cohort 5, the observational arm, and cohort 6, the fractional dose and pertussis co-administration. And so I will now pass on to Paul, who will talk about the reactogenicity and immunogenicity results we have.
Great, thank you, Eva. So we do have some preliminary results. So the reactogenicity, now, of course, this is detailed local and systemic solicited adverse events, and these are all recorded through e-diaries. So these were only women who were vaccinated in the trial as part of a trial procedure. So just to be clear, those who received their vaccines outside the trial in the routine program, we didn't have detailed reactogenicity at all on. So that's why the number is this. So it's 88 for whom we have detailed reactogenicity. And this is the demographics. You can see that in fact, most of them were seronegative, actually, at this point. And you can also see that in terms of ethnicity, as expected, predominantly white women, underrepresentation, in fact, of those of Black ethnicity. And in terms of the reactogenicity, it's presented here in terms of percentage having or reporting local and systemic solicited events. These are listed along the top. This is the second dose, this is the first dose, and then B and T is Pfizer, MOD is Moderna. So for the first dose, they either had Pfizer or Moderna. And you can see perhaps the adverse events. yellow, or none rather, is clear. Yellow is mild, moderate is orange, and red is severe. So if you just run your eye across that, and I will draw some concluding remarks shortly. And then with the second dose, we also had some AstraZeneca doses here, because though we weren't providing a first dose of AstraZeneca in the trial, because at that point it was in fact contraindicated when the trial began. For those who'd had a previous dose of AstraZeneca, they could have a second dose of AstraZeneca. So a number had it within the trial, or a number of 10, in fact. So this is the second dose recipients, otherwise Pfizer and Moderna, and perhaps there's a suggestion that there are slightly more adverse events overall. This is the third dose. The numbers are now fewer. This is predominantly Pfizer, in fact. And then this is a fourth dose, and again, the numbers are fewer again. And this is where there are some half doses. We're not going to be able to draw any conclusions, alas, around the half dose reactogenicity. So the summary of this actually is that in terms of the solicited local and systemic adverse events, there was a similar range of adverse events across the vaccines and across the doses, with tenderness reported most frequently, then fatigue, muscle ache, headache. In fact, there were very few reports of fever, which of course is very important in pregnant women. There were some, and they were after the second dose, but very few. And generally, the adverse events were mild or moderate in severity. There is, I think, evidence that there were more adverse events in the Moderna recipients than the Pfizer recipients. Importantly, there was no obvious increase in adverse events after the booster doses, which was clearly important, and this had been a concern about offering booster doses in pregnancy. But although our data are quite limited in numbers, there is no evidence of an increase in adverse events. Just turning to our preliminary immunogenicity data that we have, and we just have to pay attention to the different analyses here. And so obviously the point about receiving the vaccines in the trial was that that was the clinical trial. This is a controlled situation. It was, in the case of cohort 1, blinded, randomized, and so on. Whereas, of course, with those who were from the observational arm, there was no randomization involved. So we need to consider that, of course, and the implications of that for our conclusions. But anyway, population 1, they received 2 vaccines within the trial. At population 2, they received 2 vaccines during pregnancy, in the trial or outside the trial. Population 3, more than 2 vaccines during the pregnancy, 3 generally. Population 4, a booster dose during pregnancy. Then population 5 is for the infants, and these are the infants born to women who have had at least 1 dose of a vaccine in pregnancy. And you can see the different numbers there. Again, in terms of the demographics, very similar consideration really to the demographics for the reactogenicity data. So I won't spend any time on this. Now, in terms of the analysis, we have adjusted for a number of important variables in the multivariate analysis, and these particular variables were adjusted for in the results. Okay, and just to then pass to the first group, and these were those who received, this was the true blinded randomized controlled trial bit, where women were randomized to receive either a short interval or a long interval for the 2 doses of COVID vaccine in pregnancy. And this was blinded by use of the pertussis vaccine. This was important because at the time, and it's difficult to remember back now, but at the time that this was happening, we, at least in the UK, were not concerned, but there was evidence that a longer interval between vaccine doses was associated with better immunogenicity. And so we were, in fact, extending the intervals between doses in the non-pregnant population. But we wanted to address that in the pregnant population as well, hence this particular aspect of the trial. So I just wanted to orientate you slightly here. So this is a logarithmic scale of anti-spike IgG. We have anti-spike IgG and we have neutralizing antibody as well, but actually neutralizing antibody and anti-spike IgG correlated extremely well. And you can see the time points along the bottom. Now, the constant time point is V7, visit 7, because that's the delivery time point. Some of the other time points will vary according to the schedule. So in fact, for the short schedule, which is a six-week interval between doses, this visit 4 reflects 1 month after that second dose. For the long interval, which was 10 to 12-week interval between doses, this visit 5 reflects the 1 month after the second dose. And that's important in terms of the data that you will see. Important also because, of course, by definition, there is a longer interval between receiving the second dose of vaccine in the short interval group and delivery than there is in those who received the long interval arm and delivery. Okay, so just moving on to some of the data. So this first one is looking at the impact of vaccination interval on maternal antibody at delivery. Now, maternal antibody, be it IgG or neutralizing antibody, was the primary endpoint for the study. So that's why I'm showing it first, because we were thinking about maximal protection of the woman in the last trimester of pregnancy, which appeared to be the time of maximal susceptibility to COVID-19. Now, so here we have the antibody levels, short interval, long interval, and these are those who had it in the trial. So this was truly randomized and blinded. And then here we have it in the trial and outside the trial. So there's a degree of non-randomization here. And then this is for those who had more than 2 vaccines in pregnancy, but looking at the interval between the most recent 2 vaccines in pregnancy. Now, there is perhaps, I think you'll see a suggestion that the longer interval is associated with a higher level of antibody at delivery than the shorter interval. You can see that here, 10,000 compared with 4,200. But I'll come back to why this might be in a moment. Interestingly, that kind of disappears. These are not statistically significant. That's the first point. Second point is that kind of disappears when we start to incorporate by definition a primed population receiving another dose. So and the neutralizing antibody pretty much reflects the anti-spike antibody. So that was at delivery. Now let me show you during pregnancy and then after pregnancy. This is all in the pregnant woman. So again, this is the antenatal. So this is their antibody level at 4 weeks after the second dose of vaccine, if it was a short dose or if it was a long dose. And actually then they're very similar, much more similar. So that's this point that I showed you earlier. So if we look at 1 month after the second dose, actually there appears to be no difference between short or long interval. And then postnatally, this is now 8 weeks after delivery in the pregnant woman, there is no difference between them. And then again, this is for those who've had 2 or more. So this includes booster doses, and the same themes apply. So the summary of this is that at first sight, there appears to be a higher antibody concentration at delivery with a longer interval between the first 2 primary doses given in pregnancy, but this is not statistically significant. And in fact, there's no impact of the interval on antibody concentrations at 4 weeks after the second dose in pregnancy or at 8 weeks post-delivery. So I think the high delivery concentrations simply reflect a shorter time since the last dose in the long interval group. So just now looking at the booster dose, and I can skip through this fairly quickly. It's now looking at the first timing here is 4 weeks after that dose during pregnancy. This is the delivery sample, and this is the postnatal sample in the pregnant woman, taken at around 8 weeks after delivery. And these are all, in fact, fairly close. There is possibly in the 3rd trimester, it looks higher, but the numbers are way down here at 4. So, and again, are not statistically significant. So at the conclusion of this part, is that there is no effective interval between second dose and booster dose on antibody responses during pregnancy, at delivery, or post-delivery. And I think we can say that there's no effect of gestational age on antibody response to the booster dose during pregnancy, at delivery, or post-delivery, but really we can only apply that to doses given in the first or the second trimester, because in fact, so few doses were given in the third trimester. Just turning to the baby, we're looking at the baby population here. Very quickly, we have cord blood or blood taken within the first few days after delivery, and we're combining those in this number, I think legitimately so. And then we have also blood samples taken from babies after delivery, either at 4 to 6 weeks or 10 to 12 weeks. They were randomized to one or the other. And this just shows when all of that occurred and some other facts. I'll just skip through this though. So this is the cord blood sample now. According to the vaccine received, the last COVID-19 vaccine received in pregnancy, Pfizer and Moderna and AstraZeneca. You can see here, slightly higher Moderna, slightly lower AstraZeneca. Homologous versus heterologous, well, most of them were homologous, so limited in our conclusions. And then in terms of trimester, we have, these all look pretty similar actually. So this is the cord blood sample antibody according to when the last dose was given in pregnancy, first trimester, second trimester, third trimester, and they're quite similar. This is the placental transfer ratio, so infant antibody, cord antibody concentration over maternal antibody concentration taken at delivery. There's clearly active placental transfer of IgG, anti-SARS-CoV-2 IgG spike protein antibody. As you can see, these are all well above 1. Actually, there's relatively little difference here according to the vaccine type, and in fact, the gestation of the last dose of vaccine. And then in the babies out to up to 3 months after delivery, you can see the antibody concentrations here. In fact, again, there are no statistical significant differences, and very similar again. Notably, there's a significant decline over that first 3 months of life from birth, which is not surprising. There is still much antibody detected, however, at up to 12 weeks post-delivery, but it doesn't seem to matter when they got that booster dose or that last dose. So there's no clear difference in antibody response in infants at birth or at 6 to 12 weeks, according to whether the last dose in pregnancy was given in the first, second, or third trimesters. Placental transfer ratios are high for COVID-19 vaccines, regardless of vaccine or trimester at last dose. The decline over the first 3 months, and I think it's clear that the mRNA vaccine responses are higher than those of the adenovirus vectored vaccine, which was the AstraZeneca vaccine in this study. Okay, so there's some preliminary results. There are more to come. We're particularly interested in looking at the effectiveness data, actually, because we've had around about 150 cases of PCR-proven COVID-19 during the course of the trial in both the mothers and the babies, none of which were in fact severe, none were hospitalized, but nonetheless, it will enable us to look at some of the implications of these perhaps differences in antibody responses. And of course, it may also be helpful in thinking about a correlative protection as well. I will now pass back to Eva to talk about some of the challenges, of which there were many, in recruitment in Preg-CoV. Thanks, Eva.
Thank you, Paul. So here, there's a wide range of issues that we had with the study and problems that we came across, which we continued to look into and try to amend the trial just to accommodate them. But the ones that were of special interest here are the vaccine hesitancy. So there were many potential participants that we see face to face who were very hesitant. The maternal team here did an amazing job in speaking to eligible women and trying to address their concerns. They were obviously anxious. It's, you know, pregnancy. They would be thinking of other things as well. So they would be, there's high anxiety there. They would have other commitments. These visits that we had, as you can see from the previous slides, looking at the visit schedules, were quite intense. So it's very difficult if parents already had other commitments, which would hinder them coming to see us at site. We were seeing high-risk pregnancies which weren't eligible for the study, which did reduce our pool of potential recruits. Eligibility criteria, as I mentioned before, we did try our best to try and be more inclusive and adapt to allow for more participants to be included in the study. We came across many participants who, on speaking with other family members or partners, were then encouraged to not take part in the study, something that we would have to look into in trying to speak to whole family members, partners as well, not just mother as well. Pandemic restrictions, so difficulties at the time with traveling into hospitals, and obviously concerns that pregnant women had with coming consistently to the hospital setting and visiting the teams and other people. So that was something that we had to look into as well. And also participants not being comfortable with participating in blinded studies. Obviously, they would want to know what they're receiving, but it's again making them aware of the importance of research and why we blind in these studies. That's something that we need to improve on communication-wise.
So, Eva, thanks. I think what I might do is just move us along, actually, because I've just realized we're quite close to the end and we need some discussion. So I'm just going to flick through these, and I hope that people will appreciate all of the aspects. Just to move to reflections, if that's all right. So we just wanted to reflect and just to make the point that infectious diseases outbreaks can severely and sometimes uniquely affect the health of pregnant women and their infants. And despite this, pregnant women are invariably excluded from pandemic preparedness and response research, as well as other vaccine trials. And they were largely excluded from COVID-19 vaccine research. In fact, there are only 3 phase 2 trials of COVID-19 vaccines that have been conducted in pregnant women. One of them is Preg-CoV, and none of them have been in the European Union. There is therefore, there has been and there was a lack of evidence for pregnant women, which led to tentative, delayed and variable national recommendations, leading to vaccine hesitancy, low uptake and avoidable deaths. There are a whole range of things we could have done better in Preg-CoV, some of which are listed here. And perhaps all of these are obvious. I think we should have started sooner, for example, but all of that requires a whole range of things to do better: early engagement with key players and the preparation that is required. So one solution to all of this would be to have an adaptive trials platform that can support novel vaccines and therapeutics for infectious diseases in pregnancy and infancy, which is ready and able to pivot rapidly to emerging health threats, an ever-warm network doing studies in pregnant women ready to switch to a pandemic vaccine trial, for example, and there are a number of things that would be required to do that. But that includes doing work right now to engage all of the key parties. So I think I will finish with the acknowledgement. There are many people that have been involved, our funders as well, of course, and more information about the study is available on our website. And I will stop there. Thank you very much.
Thank you very much, Paul and Eva. Actually, it was a really excellent presentation, and congratulations for your work, because it was and is a very difficult endeavor, bearing in mind all the challenges and the difficulties. But I think your last slides regarding the reflections and the solutions are the most important ones, actually, for further discussion and moderation. I will immediately start with some questions in the chat box. So the first one comes from Zanina. and she asks, I have a question about the recruitment. Have you evaluated which one of the approaches, like the flyers, the social media, was the most successful in reaching possible study volunteers? And I think Eva already answered to the question that maybe face-to-face communication with the volunteers is the best approach. But bearing in mind that as VACCELERATE, we have a transnational vaccine registry. We would like to hear also your input and your lessons learned from the UK vaccine registry. Was it actually an efficient way and mode to recruit volunteers?
It was a very efficient way in disseminating information, I guess, and inviting. However, it was the face-to-face clinical aspect that we managed to get more participants in. And anecdotally, this was throughout all the other sites as well. It was more the face-to-face. So whilst sending out invitations through this vaccine registry would disseminate that information more widely, it's still that face-to-face.
Yeah, I agree with that. I think that's particularly so for the pregnancy vaccine trials, wasn't it? I mean, we have to say, and I know you know this, VACCELERATE, but the vaccine registry that was established in the UK for all of the COVID vaccine trials, I think was a really powerful tool for all of the other COVID vaccine trials we did, all of the initial trials. It really did allow recruitment to happen very efficiently and quickly. But I think for pregnancy trials, as Eva's saying, it's a bit different, isn't it? And that face-to-face aspect was really important. And so building that into all of the sites to allow that to happen was really important. So I think this is an example of where for pregnancy trials, a different slant is required, although the registry was still really important for advertising and telling people that these trials were there.
Mm-hmm. Thank you very much. And I think it's pretty much similar with the pediatric clinical trials also, similar with the pregnant ones. I move forward with to Kirsten's comment. Did you also you already answered, Paul, but can you?
I think, so Kirsten, I think, is probably asking in terms of what we haven't specifically shown here is the influence of the number of days, as it were, between vaccination and delivery. And yeah, we are doing that, Kirsten, as you would imagine, but I'm afraid I don't have that analysis as yet. But it's a really important question and may help to shed a light on some of these interesting results we're seeing.
And then from Ole, first of all, he thanks for the great presentation, and he asks, did you see any differences between primigravide and women with previous pregnancies?
That's a good question. I don't know that we have. I don't specifically know that we have looked at that. I'm not sure if that has gone into the to the analyses. So let me take note of that. Yeah, I don't know the answer.
This is also the importance of having fruitful discussions between consortia and experts. Paul, from my side, I think that you mentioned about the part of vaccine effectiveness cohort studies. Do you intend actually to include clinical outcomes with regards to severity of COVID-19 disease, ICU admissions, which might also be of importance for the public to show actually clinical outcomes and the protective actually importance of the pregnant vaccination?
Well, absolutely. I mean, we have characterized all of the COVID cases that have occurred during the trial. The fact is that all of them were relatively asymptomatic. And as I say, excuse me, I must be now symptomatic. No, there are about 130, 140 cases of COVID in the recipients in the trial over the entire length of the trial now. But none of them were admitted to hospital, neither the mother nor the baby. So they're all relatively mild, which is, of course, a good story to tell, because if we were to look at those who weren't in the trial, and indeed, obviously, those who weren't vaccinated, we all know that the story is different. But within the trial, because, of course, we have no unvaccinated control group. But what we do have, of course, is cases occurring at variable periods of time after receiving vaccine and after receiving different types of vaccines. So we hope to be able to use that to understand more about the timing of vaccination and protection against clinical disease. And also, as I say, because we have cord blood on all of these, to look at whether there may be a serological correlate of protection in the infants that we can estimate based on the effectiveness data.
Mm-hmm. Very, very important. And since we are reaching the end, Paul, I would like to have from you like a mini summary, very similar to the reflections and the solutions that you just mentioned, because as VACCELERATE Consortium, we are also trying, for preparedness reason, to evolve and see what are the best solutions actually to improve our framework and infrastructure with regards to pregnancy, adult and pediatric vaccine clinical trials. So if you would summarize the major challenges and, from your perspective, the major facilitators, if feasible, in few sentences, what would you say?
A few sentences is a challenge, but yeah, look, I think as I was starting to perhaps summarize at the end there, the first thing, of course, is to recognize that pregnant women and infants have been neglected up until now in all of the pandemics. And indeed in many of the new vaccines as they come through, with some notable recent exceptions, however. So the first thing is to recognize the need in this population to establish the evidence base as quickly as possible so that timely recommendations can be made, thinking about a pandemic now. And that wasn't the case in COVID-19. So we need to prepare. We need to, obviously, there needs to be the funding to establish a platform trial, which is across multiple countries in Europe, representing a range of geographies and ethnicities and other important aspects. A group of sites that are prepared, that have experience or can gain experience in doing pregnancy vaccine trials, because of course we all recognize there are some very special considerations around doing trials in pregnant women, in thinking about how to assess safety, of course, which is of paramount importance. So prepared sites who are already prepared, their capacity has been established, the protocol is in place, we know what to do as soon as we need to, a protocol that can adapt quickly to changing conditions. And one thing we did, as I think we showed you, were many things changed over the course of the pandemic, including national recommendations. As soon as we incorporated a booster dose into the trial, the national guideline would change so that a booster dose was given to everybody. So it became less of interest, perhaps, for a person to come into the trial to participate, to get a booster dose, because they could get it outside the trial. And that was also the same with the second dose earlier in the program, that it meant there was no longer an attraction for them to come into the trial because they could get it in the routine program. So we need to adapt. The guidance changed. The priorities changed. Fractional dosing was a priority at the beginning, so we built it in. It then became not a priority because it became very clear that actually there was enough vaccine to go around. That was an original concern, but as I say, it became less of a concern. So in fact, that no longer was an important objective, and so we stopped doing it. So things change. So we need to anticipate the changes that will occur during the course of a pregnancy platform trial during a pandemic and incorporate them into our preparations. And then there's all of the appropriate reaching out to the key partners, the regulators, the ethics committees, the vaccine manufacturers, so that all of these things have been considered early and so that changes occur in a timely way and with full support of these key agencies, including, of course, pregnant women.
Paul, I think we need to record the last version and play it over and over to every relevant stakeholders. First of all, thank you very, very much also for the great, let's say, summary at the end. From my side, it was really a great pleasure, and we hope that we will further collaborate, as you just mentioned, in the future about preparedness trials with VACCELERATE. I will give the floor to Zanina to close the session.
Yes, thank you very much, Paul and Eva, for this very, very interesting talk and for replying to the questions that we've had in the chat. And thank you very much, Zoe, for again supporting us as a moderator of our webinar. And yeah, hope to see you all again in the next session. Have a good day, everyone.
Thank you. Bye-bye.
Bye.